All right, welcome folks. Stephen Beeson here, family medicine physician, founder of Practicing Excellence, and welcome to This Clinical Life. It's actually our fifth episode, and incredibly important topic today, which is value-based care. And how do we actually get it to manifest? We are currently about 7% of revenue to healthcare systems is based upon value-based care. So we are incrementally moving in that direction, or you could even call it a bust in terms of moving towards value-based care as a mechanism to provide well-being to our populations. So we're going to talk about a critical topic today with an amazing guest, a colleague, friend of mine, Jennifer Rutberg, about how do we get this into the exam with those providing care. So super exciting sort of bottom-up view of how we manifest value-based care in something other than 7% of reimbursement for all of healthcare coming from value-based care at-risk contracts. So Jennifer, welcome.
Thank you. Great to be here.
So introduce yourself. You're from an internist from Banner Health, but I know that you've got sort of an executive leadership role, and tell us a little bit about that and how you're playing in the value-based world channel.
Great. Thank you so much. So again, I'm a general internist by training, and my path started in full spectrum general internal medicine, nursing home, hospital practice, office-based practice for many years in an academic medical center in New England. And more and more became interested in solving problems bigger than the ones that were in front of me in the exam room. Those relationships with patients and helping them pursue what was most important to them. I realized the obstacles that were in the way of doing that. And when I joined Banner in 2014, practiced primary care for a little while here in Colorado, and a great colleague and friend, Dr. Angela Mills, lured me back into the acute care setting, but really in a role in care coordination, where I could really bring my understanding of the outpatient world into the acute care hospital setting, and focused in part on those transitions of care back to the primary care setting. And my experiences in primary care and as a physician over those years with raising a family and juggling career and workload, et cetera, and some of my own health challenges really drew me quite passionately into the work of happiness in medicine and really the sustainability of our sense of purpose in healthcare. So I've had the privilege for the last few years of working with a really fantastic initiative within Banner Health that's been focused on a multi-pronged approach to cultivating happiness in medicine. And I probably don't even need to talk about burnout in this group, but I think importantly really came to understand with many of us the evolution of our understanding of burnout, which is that there are individual factors of resilience and self-care and self-awareness that we need to take responsibility for and get that help if we're burned out. But that so many more of the factors of burnout are systemic, and it's an occupational hazard in healthcare. And so piecing together my own experience and passion and desire to solve problems, how do we build and support systems to keep physicians and other frontline health providers, connected to their why and staying well? And that's a systemic challenge for each of our health systems and certainly for the US healthcare system. So I've helped lead from a physician standpoint, kind of the advisory committee across our multi-state health system related to that. Just now handed over the reins to my successor in that chair role, who's doing an amazing job. But it's really helped me in this topic of value think about where our responsibilities lie and where the challenges are in getting value-based care off the ground.
So, well, thank you for that. And I think that a dependency on our ability to execute value is clinicians, care team members showing up to work saying, I'm doing the kind of work that was the reason I joined this profession in the first place. And, cultivating that cultural wellness, of team
Mhm.
collaboration, purpose-driven work, making an impact, deburdening
Yes,
the clinical workflow so we can, as a team, operate at the top of our license,
yes,
and provide, and doubling down on upstream care, so we're preventative and proactive as opposed to post-patient crash interventions, which are super costly and
absolutely.
sometimes not very effective. So all the things of value-based care are consistent with the clinician life of, I'm part of an amazing crew advancing the well-being and wellness journey of the patient and the populations that we serve. It's not like a
Yes,
government policy initiative to reduce the cost of
no,
healthcare.
no,
Yes, but that's not the healthy spirit of value-based care.
right.
So let me ask you a question, and I implied this, and this is a personal bias of mine, which is uh, our value-based care journey. I mean, if you ask any healthcare executive, yes, value-based care is the right thing to do
Mhm.
for the well-being of our patients, the cost of care, the experience of care, the coordination of care, team-based care. Yes, 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 yes. Why have we been so
Mhm.
ineffective
Mhm.
in advancing the delivery and committing and assuming risk for value-based care?
Mm. It's a great question. I knew you would start with one like that, but like, how are we going to handle this
You're
one?
well.
Yes.
I'm curious. I'm taking notes, by the way. If you can let me know.
Well, first of all, I have to tell you that anything that I bring to the table for perspective or ideas today, is certainly rooted in my own experience, but also in the expertise and conversations and learnings from really valuable colleagues of mine that help me understand this, like team-based care, team-based approach to solving problems. And so really understanding why the perception can be boom or bust here, and has it fallen on its face? I would say it hasn't yet. Compared to, say, even 7 or 8 years ago, we've doubled the number of physicians who are practicing under some kind of value-based reimbursement model, which is progress.
Right.
I think we need to name the elephant in this room, which is healthcare has been under assault from many facets over the last couple of years. And there's so many pieces of healthcare that have in some ways been stunted by going through a pandemic, and really emphasize the need to be in survival mode, truly, at all levels in healthcare. And if we think about, say, our two largest models of healthcare delivery systems in the US right now, nonprofit and for-profit systems, our nonprofit health systems struggle, to make 1% to 2% profit margins. Okay. I talked to friends in other industries, like, wait a minute, did you leave out a zero in the profit margin? 1% to 2%. How can you even survive? Great question. And then our for-profit systems have stakeholders that they're accountable to. And so, meeting the demands of shareholders and investors is another whole relationship and challenge to manage. So our health systems count on being able to, we need to reinvest over and over in our systems to advance care, or however that is. So if it's a nonprofit system that's faced unbelievable skyrocketing prices for labor cost, supply chain, decreased elective surgeries, people not coming in for their preventive visits, during a pandemic, we're not getting their colonoscopies, not getting to the mammogram center. How do we make gains when we've been under that kind of pressure? Survival mode is there, right? And from all the work you've done and others in our own education with each other, we know that survival mode is not the most creative, innovative, daring, brave place to function. It's about survival. So I think, naming that and understanding that place where healthcare is it takes courage, it takes vision, and it's we've just come through such a challenging time. There's exhaustion, around taking this on. I have one other thing to add to that, which is this. Listen to me, like, hold on a second. We know that this is on clinicians, right? Well, this is on clinicians. who are the exhausted frontline workers who are trying to remember their why, and we're getting there. But now value-based care has often been seen as a top-down, one more piece of responsibility for us to do from the top down, instead of, wow, from the bottom up, what do we value? How do we recapture what we love? How do we do this? How do we get back on our feet? So I actually think, combined with that and the awareness of burnout as a systemic issue and our attention at trying to solve that, this is actually the ripest time I believe we have in recent years to make this work.
So such amazing points, in regards to how do we set conditions to allow us to transition to, a value way of delivering care.
Yes.
Kristen dropped in a wonderful note that I think is reflective. She asked the question, despite enrolling many of our primary care providers into value-based contracts, we've been tracking and compensating quality HEDIS metrics for 20 years. We are falling further behind other developed countries in quality and longevity. How do we need to change our system? And we could even make the argument of, how do we transition to value?
Yes.
And I hate the term value-based care. I mean, it sounds like a policy. It sounds like a strategic initiative.
Yes.
It should be called the right care for the right patient, delivered by a team. I mean, can we call it that? That's kind of odd. That's kind of long.
No.
But it is. I mean, it's
right.
It is.
Right.
And the other issue, I think, Jennifer, that is very interesting is our freaking death grip on fee for service. I mean, we and part of it is, the poor for-profit driving revenue to be paid by task.
Yes.
Part of it is the survival mode, and we have to keep the doors open. So we have to funnel a fee-for-service mindset and way of being to optimize productivity so we can keep that 2% margin so we can actually make payroll and keep the doors open. Right. But the bigger, broader question is, can we do value in the context of incremental, partial, minority risk? And it's almost a rhetorical question, but
right.
I would love to get your thoughts in terms of, if we were to live in a blue sky environment, we're taking shared risk where 50% of the savings are shared with the payer. Like, who cares, right? I mean, it's more of an intrusion and an irritant than it is changing how we think about preventative, evidence-based, patient-centered care versus assuming full risk. And we're doubling down on upstream intervention to optimize wellness.
Right.
My question is, with this incremental toe in the water sort of approach, what are your personal thoughts in regards to the probability of accelerating value-based care in that context?
So I've read in some of the materials around this topic, that the idea of sort of dipping one's toe in the pool. So full disclosure, I am a dipper before I jump, and over the years I've built up my courage to jump. And so that's a disclosure as far as my perspective. That's been an evolution. And we know that there are some organizations that were developed from the ground up to be full risk, owning healthcare systems. And they're doing it, and they're seeing the cost savings, they're seeing the quality measures that were brought up in the question there. So we know it can be done. And I think as we look at systems that are creeping along, and as you mentioned, 7% of our US revenue right now are in value-based contracts. I suspect, with some of our own audience members, we might have, a third, and a third who have no value-based contracts, a third who are dipping their toes, and a third who are hitting kind of that optimal percentage, which is thought to be about 40%, of your contracts and patients enrolled in some type of value-based shared risk program. And so we all have different experiences with that and different perspectives. I think our best tool is to teach each other what's possible. Okay, it was a dear colleague of mine yesterday was telling me about a leadership program she was at with some local residents who were in a primary care clinic. And I mean, these are the people who go into programs that serve rural Colorado at the end of their careers and are diehard primary care. And they look at their value-based metrics coming to them and say, how do you expect me to talk about a colonoscopy and a 20-minute visit with a single mom taking care of a kid with cystic fibrosis? I don't have the time to do this, right? That clinic, by the way, has no value-based contracts, okay? So there's that perspective, and these are people who care a ton about this. I don't know if they know what's possible, right? And we hear value-based care, and it's like, oh, one more thing for me to do. Well, let's hear about these places that are closer to the 30-40% mark, are getting shared savings back. I was in one of these practices early on in these models. I had a medical assistant who I shared with another physician who helped manage my population of patients. Those monthly reports on my high ED utilizers, the patients on high risk medications, the ones missing their colonoscopies, and they did the work and got those patients in to get their testing or to see me more regularly. And so I know what's possible if we can get there. So, and guess what we do in healthcare as physicians? We're smart people. We're smart people. We're creative and we're leaders. And if we can learn what's possible and put this on our agendas for education and start with what our own clinics can do and start making the case for this at the highest levels in our organizations, we have a tiny bit of revenue. How can we invest in our teams so that we can move that quality and cost value measure in the right direction?
No, I love what you're saying, and some fantastic comments that are coming in. Casey, thank you for mentioning just the power of, social determinant integration. I mean, that's just, everybody's read the data that the clinical intervention is actually 20% of the wellness equation. And, part of a value-based care journey is preserving the wellness of our patients so they can have the life that they envisioned. I mean, what a great calling. I mean, it's not value-based care and metrics and blah blah disease registries. Those are tools. That's not value-based care.
Right.
And so I agree wholeheartedly, Casey, for us to have the space and the time to determine the conditions that patients are living under. And to help and support, to partner with our community. In fact, I was just talking with some folks at Virtua and some of the amazing stuff that they're doing to bring food to those that have food insecurities. And they're using their philanthropic arm to help fund it. But it's like the most invigorating part of what they're doing, because we're getting back to helping people in really compelling ways. And sometimes it's a colonoscopy, and sometimes it's getting them fresh vegetables.
Absolutely. I love that comment. Bringing in that whole topic of social determinants and risk. And it's absolutely true and it's why it's so important to know your patient panel. And I think that's an incredible starting place of knowing your patient panel, knowing the people who are falling out and why, and understanding why. And is it food insecurity? Is it a bad prior experience with healthcare? Is it they need a little more frequent visits? Make space for those patients, not the ones who are perhaps, not suffering from food insecurity, are tech savvy and would be thrilled to just have a quick video call from their doc, or have a medical assistant call them with their normal lab results, right? If we can really get sophisticated with and understand the tools that are out there to do risk assessments on our patients and identify the patients at highest need, I think how valuable that is to a patient suffering with basic needs.
And if we were to effectively have a mechanism and a tool to assess social determinants and have a process referral process to be able
Yes.
to access and bring needs to those patients, and following important metrics like readmission,
Mhm.
ED visits, high utilization, care costs.
Absolutely.
Casey, I think
Yes.
that's what you're saying, and what your system is doing. I want to mention another question. Again,
Yes.
I think that the term value-based care in the equation of quality multiplied by experience divided by cost is, I think it understates really what
Mhm.
value-based care is. And I know
Mhm.
I've said that again and again.
Yeah.
And I want to talk about how we go from it being a policy strategic initiative to bringing it into the motor
Mhm.
end plate of healthcare, which is between
Mhm.
care team members and patients, that micro interaction, right? What Berg
Mhm.
described as that's where healthcare actually manifests, right?
Mhm.
And the
Mhm.
only purpose of policy and strategy and all it's got to be able to cascade to impacting the patient. Otherwise, it's a bunch of blah, 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 and talking
Right.
and
Right.
ideating and admiring and measuring. It must
Mhm.
execute with action in the exam
Mhm.
room to
Mhm.
really advance value. So
Yes.
let me talk about the children, if you will, of value-based care, right? The components that the listeners today can begin to say, we can get after that. That's maybe not
Yes.
our value-based care initiative, but it's something that we can pursue, that our clinicians and care team members would say, yeah, heck
Yes.
yeah, we want to do that. Things like
Yes.
identifying what matters most to patients
Mhm.
and what their goals are. Uh,
Absolutely.
that
Yes.
is, I mean, so
Absolutely.
talk a little bit about
Yes.
that in terms of how we
Yes.
might, as one of a number of dials, just say, as an
Yes.
organization, we are going to begin to say to patients, what about all of the things that are in front of you are the things that matter most to you, so I can be a partner with you to get that done.
Absolutely.
Talk
And
a little bit about that.
Stephen, I think you may have used these words, or someone on your team, but these are the superpowers of primary care. This is what drew me into primary care, and it's still what guides me daily. So often is that the answer is in their story. It's in the
Right.
patient's story. And what do we do in exam rooms? We ask questions and we listen. We build relationships. We build trust. Um, we don't typically have to work hard or pretend to be interested in our patients, right?
Right.
That is our gimmick. Okay, it's our high tech tool. Is those relationships, and so we come into that exam room with the understanding of care pathways, of best evidence, of best medicine that we want to deliver, but then we have to figure out what's right for the patient in front of us, in their circumstances and their values and their goals. Something's only valuable. You just think about the term value, or even valuable. It's something
Right.
that's precious, that's worthy of respect, that is seen as important and useful. It's got to be useful. And so when we're in that exam room with our patients and we get lost in, like, did they have their colonoscopy? Am I referring them to the right specialist? Wait a minute. What do you need most? And I want the same thing for you, obviously within reason, right?
Yeah.
Establishing that shared value with them and then advocating for that. Like, this
Right.
is what we do. And we create that safe space for them to disagree with us or ask questions or push back and say, there's no way I'm going to go get that heart catheterization before I get to my son's wedding next month. Right?
Right.
Perfect.
Right.
Right? Perfect.
Good to know. Good to know. Right.
Or,
Right.
hey, they're never going to have a heart catheterization. Let me back up. What can you do, or do you see as possible to help contribute to this goal with your health, right? Of being able to walk to
Right.
the edge of the baseball field to watch your grandson's baseball game without chest pain. What are your strengths? What can you do? And think of what you just saved from referring them to a specialist that they have to get to, go to the visit, talk all through everything, get a test set up, and then they don't show up for it because it wasn't important in the first place. This is
Right.
value.
Right.
And
It-
yeah,
So, I mean, what was so beautifully said is that we don't think of value-based care as a strategic pressure to bend the cost curve in American healthcare. It's just framing it wrong. It's what is valuable for the patient,
Mhm.
and a part of that is what matters most to you. And
Yes.
I would contend, based upon my shadowing of 800 clinicians over the last 20 years,
Wow.
looking at the literature, 20 plus years in clinical practice, is that the numbers of times that clinicians have deliberately and specifically said, I want to find out what matters most to you in your
Mhm.
health journey,
Mm.
is, let's just say, not all the time.
Right. We
Yeah,
lose this.
right,
We lose that
right,
sometime in
right.
with all these other variables coming at us.
Right. And it's the essence, it's the foundation of value-based
Mhm.
care, is to identify and to partner and to make your therapeutic goal
Mhm.
what actually matters to the patient as a specific way of
Mhm.
communicating and partnering with them. Um,
Absolutely.
so you mentioned, so that would be, that's an example of something that we could bring value-based care into the exam room without calling it a disease registry and
Mhm.
the other
Mhm.
tools and instruments, and sometimes what feel like intrusions of
Right.
value-based care. We're
Right.
simply going to find out what matters most to patients
Yes.
and what they really truly value. And that is going to be a commitment and a promise that we will make as a group. And we're going to come back and debrief and tell our stories about what we discovered. We were worried about this, they were worried about that. And the fact that we were now listening and
Yes.
partnering on the things that matter to them formed this trust and partnership and relationship and alliance
Yes.
that was
Yes.
incredibly therapeutic and effective.
For
So
both of us, Steve, right?
for both of us, yeah.
Right?
So
Right?
the second, yeah, the second child of value-based care is adherence to evidence, right? You mentioned that is, that's a
Yes.
channel that we're very familiar with.
Mhm.
So talk a little bit about, evidence-based care as
Mhm.
as an expression of value, and
Yes.
kind of where we are and what we can do to help bring value into the exam room by saying we will adhere to evidence as
Mhm.
our charge
Mhm.
to pursue what matters
Mhm.
to the patient. So talk a little
Right.
bit about
Right.
how do we build an evidence-based care
So
approach.
and again, that's getting back to like, right, that the best of the medicine we have and the right thing for the patient. And um this is humbling. I looked at the statistics on this and I thought I had them backwards. Uh so I'm a physician, so I can say this about us as physicians. 90% of us probably think we're in the top 10% of performers as physicians when it comes to value, to adhering to care pathways or evidence. And it's we're not. And we struggle with that, the human tendency to want to individualize, deliver care. Sometimes in certain situations, that's because of a case we saw once or the pressures of the patient in front of us. And it across some research in primary care, only 30% of us are using care pathways reliably. And that's tough. And I can even say, well, but this didn't apply to this patient or that patient. Well, I have to really get honest with myself and ask why. And what's the barrier to that? And when we vary from some tried and true pathways that may be appropriate for 70 or 80% of our patients, we have care that's all over the place. The back pain example that's now pretty well understood across all of primary care. What percentage of our patients really need an MRI or a referral to spine surgeon or orthopedics? And we do that, I think, because patients want it. Maybe we feel like, gosh, I really don't feel great about how to best approach this with this patient,
Mhm.
or I just don't have the time, so it's easier to order an MRI. Everybody's happy. They've got great insurance, so it's covered. And then you can sometimes end up down the rabbit hole of doom with the unneeded MRI. And we have the support from these care pathways that can really help us understand which patient needs the MRI, which patient needs a path of, good stretches, exercise. In 6 weeks, you're going to be in the same place as someone who had the MRI, and share that data and that thought process with the patient. I have the same goal for you. I want you to get pain-free back to gardening. In my experience, and with all these thousands of patients who've been studied, you know what? I'm not sure if you need the MRI because I always use the term, it's not the tunnel of truth. They're like, wait a minute, what? We don't necessarily get our answer that way. I have confidence that if we take this pathway and I see you back if things aren't getting better, this is what we'll do then. This is the referral pathway we talk about. If these things happen, patient can leave then with that 6, 8, 10-week mental course of what to expect and the trust that they're going to come back to if it doesn't work. So
it is. And again, this is another child of value-based care. Another foundation of value-based care is not only identifying what matters most to patients, adhering to evidence, but also the skills of how do we communicate with patients when they may be requesting things that their neighbor, the chiropractor, had suggested to them.
Right.
And no disrespect for chiropractors, but there's been 100 times where I've gotten that narrative as a primary care clinician, right?
Sure.
And so what I have found is that how do we equip clinicians to build decision support, care pathways, and choosing wisely in our back pocket, so we have reference to show patients that there is robust research that has been done on conditions just like yours.
Right.
What I found is that the context that we set as clinicians to find the root cause for the request, to be able to validate the request. My goodness, if I would have read that report, I would be asking for the MRI as well. Totally get it. And to build a shared interest, which is, you know what, we want the same thing. We want to make sure there's nothing bad going on and to get you better. And then to be able to leverage, and those conversations is a skill set, just like, is this a mechanical back pain, medical back pain, or radicular back pain, and which care pathway will I go down, is how we interface with the patient. So the patient walks out, oh, they care about me, totally confident in them. I got a peek inside how they think. And I got to see the evidence in a pamphlet that was actually in the exam room. I'm good. So this is, identifying what matters most to patients as I hate to use a word, but a value-based care initiative, right? I mean, that is driving, building an evidence-driven care system, and using data, education, learning, and clinician interaction skills. So we're not just saying, well, the care path, the choosing wisely says this, and you're going to go to war and it's going to be bloody. And then the third and last one I want to talk to you about as an expression of bringing value-based care into the exam room is really team-based care, right? I mean, it's utilizing our team. So it's not that clinician worrying about the colonoscopy. It is a group managing the patient on the schedule and outside the schedule to preserve the well-being and upstream care intervention for the population we're responsible for. So talk a little bit about team-based care and how that can be a child, if you will, of value-based care.
Absolutely. So I think back to medical school, right? Individual success, the individual performer on rounds who knew the answers was the one that stood out and was rewarded. This sexy legacy of healthcare is doctors being, the sort of solo hero, who's going to save the day, and how far we've come from that model, and yet how some of that can still linger in our narratives and in our vision of healthcare. And people sometimes just don't know how to work in teams, but I think we've come a long way on that front. But acknowledging the historic baggage that we might have inherited through some of our doctor DNA, I think is important. So teams, right? Teams can vary in sophistication and in volume. If you're in one of those practices with no patients in a value-based contract where you have no extra resources for this, start small. Understand your team's why. Understand your team's bandwidth. Is there someone on your team who just got through colon cancer and is passionate as an MA about making sure patients get colonoscopies and talks to them about their fears with that? Tap into that, like know that passion from that team member. And if quote unquote, all you can do as a team is carve out an hour once every 2 weeks to say, who are the patients coming in next? Do I really need to see them now? Who are the ones who aren't on my schedule, who I'm thinking I need to see, who might have just been in the emergency room? Or let's pick one thing for the next couple of weeks with our patients. Let's find everybody who was just in the emergency department and make sure we're getting them in. You know, picking something that can impact a population of patients and make sure the team understands why and engage in that process. And I think also understanding their bandwidth, what's too much sometimes, right? And all the way up to more sophisticated resourcing on these where we can have practices where that team is a behavior therapist or coach in your office, a clinical pharmacist in your office, because maybe you're in a health system that's got closer to that 40% value-based contracts that we're edging toward, and you've saved money. And so you've invested that into your office, into a team, so that you're not in the office with that patient as a single mom with a kid with cystic fibrosis who's now homeless and trying to also remember if they've had their tetanus booster, right? It's because that's been checked off, handled, prepped, and ready to go by your trusted team partner. And the joy in that kind of work it's infectious when you can start to see your outcomes. For sure.
And there's so many amazing points there. First of all, if you look at care team members that are super engaged in their work and they're going to stay, they're doing things that are contributing in a meaningful way that make them proud of who they are.
Absolutely.
And so I think the idea, in fact, I was at Intermountain last week and I was at a clinical site, running on a clinical site up at Superior Clinic. It was an appropriate name for this group. I mean, it was amazing, amazing culture. And so their MAs had created a registry of callbacks, and it was patients that they were worried about. Patients either through they were having a difficult time getting into clinic. They were using, there were things about their history that there was a clinical concern about. There was a cost barrier in affording copays or medications, but there were sort of a agreed upon criteria, and they had this registry of patients that they were doing callbacks on. And this is all independent of the clinician. The clinicians were aware of it, but the MAs just owned it, and they proudly told the stories of what it was like to contact those patients, what it was like to get additional help and support for them where they needed it, when they had the authority by which to book another appointment because the patient was really struggling with something. And there was such beaming pride that we were given the power to innovate locally, to do what's right for the patients that we serve. And they were glowing, and their leaders were good enough to pass the power to the front line, which is a key to engagement, and where innovation and personal safety and sense of gratification and contribution come from. To say, well done, group of MAs. And I said, now you got to figure out how to take that best practice and diffuse it everywhere, because that's incredible. And so, I think that, as we've spoken about, three expressions, I call them children, three expressions of the term value-based care, which is identifying what matters most to patients, adhering to evidence and what is the best and most proven intervention, and tapping your team to allow them to innovate, contribute, participate, and feel what it's like to act in accordance with why we joined this profession in the first place.
Yes.
And then if we had more time, we would talk about how do we activate patients to care for themselves.
Of course,
That's another,
it's a whole other topic.
that's a whole other, right.
So Stephen, when I was telling, my family and colleagues that I was doing this conversation with you, they're like, you're talking about what? Like, don't you usually talk about like resilience and systemic, burnout, or just talk about ethics, or like value-based what? And I was like, you can geek out on this, guys. This is such interesting stuff, because look what it comes back to. It's, all this foundational work that you and your group have done and reminded us all of, which is how to build those teams, how to find your why, creating psychological safety for that MA to speak up about a patient they're worried about and be given the authority to make it work, building engagements, understanding your own why, taking ownership over finding joy and purpose. It makes value-based care sound really amazing. Right. It's like, this is what it is.
Yeah. Healthcare has not been good at framing initiatives in ways other than transactional and incentives.
And inspiration and transformation, right?
Yeah. No, it is. And that's what value-based care is. We have to convert it to a language that connects to the exam room and the front line of care, to mobilize us to execute against it, even if we're not under value. Are we going to not adhere to evidence because we're not in a value-based care contract? Like, what the hell? We're not going to do team-based care because we're not in a value-based care no, these are not transactions. These are not governances. These are the right care for the right patients at the right time, for the right price and cost, according to what matters to them. That's what actually value-based care is. And so anyway, Jennifer, thank you so much. I want to recognize you in particular. Practicing Excellence is under construction and is now launching our new value-based care program, using micro-learning to educate care teams on the essence and the spirit and even the operations of value-based care. So, and you've been a big part of the faculty, and I haven't seen your videos yet, but I hear you're a rock star. So yeah, that's right. No, you can. Apparently, our production team says you were fantastic. So
well, they are fantastic, and I really appreciate this as a privilege to try to excite people around this.
Right. And anyway, so thank all of you. There's a ton of comments, and we're gonna capture these comments and questions and follow up because we didn't have a chance to answer all the questions. Contact information, Deb, certainly. Jim, how are you? Best example is providers getting paid for payers who are paying for value versus volume. It's really interesting. I would look at the groups that are assuming high degrees of risk and how they're modeling theirs. I know Banner's goal is to have 50% in the next 5 years. Ed Clark had mentioned, and David Valenzuela. So I would look, the CHIM meds of the world and how they're doing it to give you sort of a future state ideas. But I can also tell you with confidence that if we were to adhere to evidence, if we were to identify what matters most to patients, if we were to highly effectively use team-based care to de-burden clinicians, engage our team members, create local innovations and best practices, and utilize the TAPA license to intervene for a population of patients, if we were to optimize transitions of care from inpatient to outpatient, if we were to double down on preventative care upstream, so we're doing, again, the pre-crash intervention to keep patients well, and have definitive interventions on high-risk patients based upon high comorbidities and health coaches to identify, monitor, and keep those patients out of high-cost centers, and we were to receive capitated revenue and manage our patient population like that, you would not have a 2% margin. And lastly, you would keep your patients in network, because leakage is a financial hemorrhage. But a lot of the countermeasures for leakage is which is a terrible word, by the way.
Yes,
We should yeah,
it's okay.
yes. Anyway, you know
We
what I mean.
forgive you. Yes.
It's graphic, but we know what I mean, right?
Yes.
But a core of that is kind, compassionate partnership with the patients, which is, again, one of the core elements of delivering care that patients value. And so anyway, this is tying value-based care into a language and to a operational pursuit that sounds less like a Medicare Advantage HCC coding RAF manipulation than it does best and right care for patients, delivered in accordance with why we're in this healing profession. So we will be in touch. Super grateful to all of you in attendance as we all battle the day-to-day slog of trying to do the right thing for the right patients at the right time for the right price. And I hopefully this will be encouraging to you in regards to how do we get this to simple things that clinicians and care team members, so we can leverage not only policy down, but bottom up, because we have to have a bottom up strategy and we have to have a top down strategy to move with the massive inertia of American healthcare, because we're so bad at agile change. So with that, thank you.